and good morning, everyone. It is my honor to join you all today to talk about commercial tobacco use and mental well-being. Before we begin, I want to go ahead and just say that I'm thrilled to be working with the state of Kentucky. They've joined our community of practice, which was basically a community practice with different state tobacco control programs to work on mental health for a while now. So we were working with them, I want to say 2 years ago. Heather and Ellen, correct me if I'm wrong, but it's been very exciting to see all of you today just making a purposeful effort to better collaborate with local community mental health centers and other partners in the behavioral health space. And hopefully you all walk away today with a better understanding of some of the commercial tobacco-related disparities impacting individuals with mental health and substance use challenges and how to address these disparities in order to advance health equity. So today, as Ellen mentioned, I'm representing the National Behavioral Health Network for Tobacco and Cancer Control, part of the National Council for Mental Wellbeing. And I just wanted to give you all a brief overview of what our network does. The National Behavioral Health Network for Tobacco and Cancer Control, otherwise known as NBHN, as Ellen mentioned, is one of the CDC national networks. It's a 6-year program that's operated by the National Council in partnership with the Smoking Cessation Leadership Center, the Behavioral Health and Wellness Program, and the Michigan Public Health Institute. So I'm sure you've attended at least one of the webinars or various training and technical assistance offered by either us or one of our partner organizations, because they are the leading voices around mental health, health equity, and commercial tobacco use. I also mentioned that this is a CDC network. We're jointly funded by the CDC's Office of Smoking and Health and the Division of Cancer Prevention and Control. So I'm glad to see your state is also working with the cancer control programs as well. And our network focuses on providing our members with resources to support their efforts in addressing cancer. So if your cancer control program needs assistance, please send them our way as well. And like our name mentions, we exclusively focus on individuals with mental health and substance use challenges, and our main activities include a member-exclusive listserv, a monthly e-digest, state strategy summits, community practices, consulting, webinars, trainings, and presentations, just like this one. So before I begin, I just want to share a common ground in terms of language with all of you. Here at the National Council for Mental Wellbeing and NBHN, we are committed to changing the conversation around mental well-being to be more inclusive of those with mental health and substance use challenges. And each of us contributes to inclusion. We all have a role to play. And the culture that we create is a result of all of our missions to ensure that everyone has access to comprehensive, high quality, affordable mental health treatment when they need it. Our inclusive culture inspires us to connect, grow, and respect others and their cultures as well. And as such, we're defining some common terms and language you may hear throughout today's presentation. The first is mental well-being, which means thriving regardless of a mental health or substance use challenge. Commercial tobacco use, which is the use of commercial tobacco and nicotine products, which includes vaping and electronic nicotine devices, also known as ENDs. And last but not least, all references to smoking or tobacco use that I used throughout this presentation is referring to commercial tobacco use only, and not the sacred and traditional use of tobacco by some American Indian and Alaska Native communities. So before we dive into the impact of commercial tobacco use on individuals' mental health and substance use challenges, I want to frame this work around health disparities and health equity, really understanding the root causes and drivers of health and illness. As we all know, smoking is one of the main risk factors for a host of chronic diseases, including cancer. So why do individuals smoke, and why does this disparity exist in the first place? We know that our health is determined by other factors in addition to our own behaviors, often outside of our locus of control: the environment, access to care, quality of care, community and societal factors. And by now, all of you have definitely heard about the social determinants of health. Thing is that without considering these other factors, we're left somewhat lacking in our approach to address disparities. So we must consider from a systems perspective what puts people at risk and how can we craft interventions in response to these drivers. So just a bit of a history lesson for you all. What makes nicotine addiction and tobacco control so complex in the United States and globally is this long history of influence by the tobacco industry and its predatory practices in various communities, including those with mental health and substance use challenges. All of you have probably heard a little bit about this through various communities. Specifically for my priority population, in the past, tobacco companies advertised cigarettes as both sedatives and stimulants. Ads in the 1950s worked to convince consumers that cigarettes would calm a person down when they smoked or felt nervous or felt sluggish. And this was a prime example of targeting with those with mental health and substance use challenges. There were many other targeting done. So like, for example, tobacco industry used to send money to state legislators to block smoke-free facilities as well. So that was something that, has decades of influence, and you'll see later how this impacted some of the services and policies offered by mental health and substance use facilities in particular. In addition to the targeting done by the tobacco industry, we see a huge disparity exists in this population because of high rates of ACEs and trauma, which I'll dive into later, and limited access to high quality care. So I just mentioned past predatory practices by big tobacco, but the fact remains is that these predatory practices are actually still happening today through e-cig and vaping companies that are using the same playbook to target communities by making vapes and e-cigs seem fun and cool and harmless. You'll see like on the screen, like very large similarities between the old advertisers and the new advertisers as well. I mentioned the access to care is a driver of disparities, and there are unique barriers to accessing high quality care for individuals with mental health and substance use challenges. So these barriers include personal, social, healthcare delivery, and policy barriers, so it spans the continuum. And while countering the impact of tobacco industry influence is important, and it's an important strategy for state tobacco control programs, it's also equally important that tobacco control strategies consider reducing barriers related to accessing mental health and substance use treatment services. So for example, one way we can overcome healthcare delivery barriers related to affordability of services is to provide additional coverage and availability of nicotine replacement therapy and counseling through quit lines. So now that we've gone into some of the barriers that individuals seeking mental health care face, let's start talking about why people start smoking in the first place. I'm sure you all have your guesses, and based on your own lived experience, you probably know somebody that smokes or have a family member, or maybe you yourself in the past have smoked. We covered, again, the impact of marketing and advertising on social behaviors and on exposure, but smoking risk is also impacted by health risk behaviors, high rates of adverse childhood events and trauma, and limited access to high quality care. In particular, I want to draw your attention to trauma and stress, which unfortunately impacts a lot of individuals even before they start smoking. Yes, I see in the chat box somebody said low rate of educational attainment, and yeah, that definitely goes back to the social determinants of health. And I know that this presentation is specifically about individuals with mental health and substance use challenges, but I encourage all of you to look into intersectionality and how different social identities and advantages and disadvantages play into commercial tobacco use prevalences. So going back to trauma, we know we have very high rates of trauma and mental health and substance use treatment settings, and a few examples of this is to frame it out for you include 76% of adults with a history of trauma experience at least one psychiatric disorder in their lifetime. And it's also almost universal among people with lived experience of mental health and substance use challenges, regardless of racial and socioeconomic differences. For example, 43 to 80% of individuals in psychiatric hospitals have experienced some form of physical or sexual abuse. 51 to 90% of public mental health clients are exposed to trauma as well, and 2/3 of adults in substance use treatment facilities report child abuse and neglect, and these are all different forms of trauma and adverse childhood events. So on screen, this chart helps us to understand how the dose-response relationship between ACEs, which is adverse childhood events, and smoking really works. So if you can, imagine 100 people who are all ACEs free, 6 of them smoke. You can think of this as the people who will smoke whether or not there are ACEs in the world. And their smoking may be caused by genetics or access to cigarettes or learning to smoke young because the adults around them smoke. These are also the people who tend to quit when presented with information about the dangers of smoking. Okay, so now imagine 100 people who have each had 3 ACEs. So from 0 to 3 ACEs, 11 of these individuals smoke. And as you can see, the risk of smoking increases with the ACEs. So now imagine 100 people with 7 ACEs. 17 of these individuals smoke. The risk basically accumulates as the ACE score increases, and the portion of smoking that is attributable to ACEs is tied to the change in risk. Smoking is responsible for 443,000 deaths each year in the United States, including 30% of all cancer deaths and 80% of all deaths from heart disease and COPD. So, there's a really strong connection between trauma, ACEs, smoking, and chronic disease as well. So ACEs can have lasting negative effects of health, well-being, and as well as life opportunities, such as education, such as job access and potential. These experiences can increase the risks of injury, sexually transmitted infections, maternal and child health problems, including teen pregnancy, pregnancy complications, and fetal death, involvements in sex trafficking, and a wide range of chronic diseases and leading cancers of death, such as cancer, diabetes, heart disease, and suicide. This is really important for you all because, as Ellen has told me, that a lot of you work in chronic disease and public health prevention. And maybe coming into this presentation, you thought, mental health is not your forte, but it's all linked, and preventing ACEs could potentially reduce many health conditions. So for example, by preventing ACEs, up to 1.9 million heart disease cases and 21 million depression cases could be potentially avoided. The good news is that thanks to changes in access, education, social norms, policies, and funding, the way we approach tobacco control as public health professionals and the way that public perceives smoking as a risky behavior has drastically changed. Today, we know that tobacco can lead to many types of cancers and chronic conditions, other than those directly related to the lung, and thanks to the 2014 Surgeon General report and also the 2020 Surgeon General report, we know that there have been published reports on the harmful effects of smoking. Through these reports, there were 4 major findings, which included smoking hurts almost every part of your body, it causes disease, and is bad for your health. Quitting smoking can make you feel more healthy right away, and it will make you even healthier the longer you have quit. I know the American Heart Association and the American Lung Association have these wonderful infographics that shows you, like, within 1 minute of quitting, within 1 day of quitting, how the lung is healing, and your health returns to normal in a couple of years. So that's really amazing. And we're finding out that more and more health problems are caused by smoking as well. So almost every time this report is published, I feel like a brand new cancer or another chronic disease is added to the growing list of illness that smoking causes. Another thing we learned is that exposure to secondhand smoke has been causally linked to cancer, respiratory and cardiovascular diseases, and to adverse effects on the health of infants and children as well. So it's not just about the individual that's smoking, but also secondhand smoke and third-hand smoke. And smoking is still the leading cause of death, and these deaths can also be prevented. It's also the #1 preventable cause of death. So smoking harms people of all ages, including unborn babies, infants, children, adolescents, and seniors. So it's really important that we approach this from a population health perspective. On screen, you'll probably see a little article clip that says psychiatrists lag behind other specialists in addressing patients' tobacco use. And you'll see that, only a little bit over 50% of psychiatrists are screening when they're meeting up with clients, which is disappointing, but at the same time, it provides a huge window of opportunity to work with psychiatrists and other behavioral health providers. And we also know that tobacco prevention, treatment, and control is, again, one of America's greatest public health achievements, and that's something to celebrate. And smoking has drastically decreased among the general population as a whole. However, when you look closer, high rates of tobacco use are prevalent across many priority populations and marginalized communities, as shown on the screen. It's also worth noting that many studies also fail to consider intersectional identities. So you can imagine that folks representing more than one priority population face even greater barriers and worse outcomes when it comes to commercial tobacco use. Apart from trauma, we also know that socioeconomic disadvantages are tied to higher tobacco use risk. Factors such as unemployment and poverty, low education, disability, serious psychological distress, and heavy drinking. Interesting thing is they did a study and about 14% of individuals without any of these forms of adversity smoked, but with each added disadvantage, smoking rates increased, rising up to 58% for those individuals that had all 6 forms of adversity. This makes disadvantage a common denominator across marginalized groups who have high rates of commercial tobacco use compared to the general population. And disadvantaged individuals are more likely to start smoking and less likely to quit. So it's our responsibility as public health professionals and community-based service providers to identify these disadvantages and provide support to improve equity by leveling the allocation of resources. So you all have probably seen some form of this statement that usually starts with mental illness. People with mental illness die on average X amount of years than those without. And that number usually ranges from 5 to 25 years based on differences in data collected by CDC versus SAMHSA. Either way, this is a significant number of years that's stolen from people with mental health and substance use challenges, and we usually don't think about why. So let's finish the sentence. People with mental illness die on average 5 to 25 years earlier than those without mental illness due to complications from smoking-related illnesses. So tobacco use is the =1 cause of preventable death again, and it's not an individual's mental illness that ends up killing them, or the substances. It's the actual substances that they're using. It's the commercial tobacco use usually. Although there are other substances that are usually priority among mental health and substance use facilities. And what ends up happening is that commercial tobacco is often not seen as a large enough threat compared to these other substances. As a result of the drivers of commercial tobacco use that we just discussed, 40% of all cigarettes smoked by adults are by adults with a mental health or substance use challenge, even though they only make up 25% of our population. And so you might have noticed I said, a mental health or substance use challenge. And, if you look at research articles, it's for somebody that has a comorbidity, meaning they have a mental health and a substance use challenge, or they're using multiple substances, that number tends to increase. So I know I just threw a lot of bad news at you all, but let's talk about some good news. The good news is that overall cigarette smoking is trending down. There's been a significant change in how people perceive commercial tobacco. It's not the trendy, cool product it once used to be, and we as public health professionals have come a long way in changing policy and practices to counter the influence of the tobacco industry as well. And while we've done an amazing job with the general population, we still have a long way to go when tailoring policies and practices for individuals with mental health and substance use challenges. So when we look at who's still smoking, we see that there are disparities within disparities, and even among people with a mental health or substance use challenge. Individuals with severe mental illness, such as bipolar or schizophrenia, have rates of commercial tobacco use as high as 60%. And to dive deeper into data, we can see that across several years, individuals with a past behavioral health condition, meaning that the person has either a mental health challenge or a substance use challenge, they have commercial tobacco use rates twice as high than those without. And current smoking among adults with just any mental illness, so like depression or anxiety, was 27.2% compared to 15.8% for those without in 2019. Current smoking among adults with a past year's serious mental illness, such as bipolar disorder or schizophrenia, was 33% compared to 17.3% for those without. And for those with a substance use disorder, such as alcohol use disorder or opioid use disorder, we see smoking rates are even higher at 42% compared to 16.1% for those without in 2019. So again, the good news is that we all have the power to change the data and do something to address these disparities. It all starts with partnering with mental health and substance use treatment facilities who provide these windows of opportunities for all of us to increase tobacco prevention, treatment, and cessation services. Starting from the bottom of the table, unfortunately, a lot of facilities lag behind when it comes to providing services. So for example, unlike hospitals, mental health and substance use facilities aren't required to have tobacco-free grounds, which is why only a little over half of mental health facilities have comprehensive tobacco-free campuses, and less than 40% of substance use facilities are tobacco-free. And then when it comes to providing non-nicotine cessation medications, less than 30% of mental health and substance use facilities are offering these treatments. And on the other hand, with nicotine replacement therapy, only 30.3% of mental health facilities provide NRTs and 35% of substance use facilities. For cessation counseling, substance use facilities are adopting this practice at a much higher rate than mental health facilities at 62% compared to 47.4% in mental health facilities. And then last but not least, over the past several years, both mental health and substance use facilities have made great advancements in providing basic tobacco use screening, with mental health facilities at 62% and substance use facilities at 76%. So that's a huge step, because that's the first step to finding out whether or not a client is smoking, whether they're interested in quitting. So we definitely have a long way to go, but more and more facilities are adopting these tried and true practices and treatments to address tobacco-related disparities in behavioral health care. So you all are probably wondering how Kentucky compares at this point. So the good news is that 69% of facilities have some commercial tobacco use restrictions on their grounds, which is a huge achievement for your state. Unfortunately, only 20% of facilities have comprehensive tobacco-free policies, meaning they cover all commercial tobacco use products, include outdoor spaces, but this provides a window of opportunity again for us to go back to the facilities that have either some or no restrictions and to expand their tobacco-free campuses in your state. And we know that this is the first step to promote tobacco-free living as well, given that 57% of Quit Now Kentucky callers report a mental health or substance use challenge. We know that having that statewide comprehensive tobacco-free grounds in behavioral health facilities will make a major impact for this population. So for tobacco use screening, both mental health and substance use treatment facilities are around the same percentages, hovering around 65%. And it's comparable to the national rate. And then for cessation counseling, Kentucky is unfortunately lagging behind the national rate, but fortunately there are many brief interventions and counseling practices that can be easily integrated into patient care. Both the provision of nicotine replacement therapy and non-nicotine cessation medications is lagging behind the national rate as well, but we know that these treatment services can be greatly expanded through tailored quitline services. So it's important for Quit Now Kentucky to be able to provide these treatments to callers reporting a mental health or substance use challenge and have a specific tailored protocol for them. So I do see a question about mental health and substance use treatments and individuals' ability to quit, and I'll get into that right now. So as you all know, there are tons of myths around why it's hard for people with mental health and substance use challenges to be motivated to quit. And I'm here to tell you that that's fake news. So let's get into the facts. The majority of persons with mental illness and substance use challenges want to quit smoking. Individuals who smoke are more than twice as likely to quit for good with the help of tobacco cessation medication and counseling services. And in fact, persons with mental illness and substance use challenges can successfully quit using tobacco at rates similar to the general population. So I don't know exactly what that percentage is, but it's the same as the general population, which is important to remember. And then smoking cessation can also enhance long-term recovery for persons with substance use challenges. So for example, if someone is trying to quit smoking at the same time that they are quitting drinking, they can have a 25% greater chance of staying sober. This last point is especially important because we always hear from states and public health leaders that their mental health and substance use facilities don't want to prioritize tobacco use over other substances. Usually it's like, they want to talk about opioids and the opioid crisis, and like commercial tobacco use usually comes last, or tobacco, unfortunately, a lot of times in these facilities is substituted for whatever substance the person is addicted to. But the fact is that quitting tobacco can actually enhance long-term recovery when using a co-treatment approach. And it's really considered a success in a lot of ways. Like, we wouldn't consider it a success if we get a client to quit alcohol and to recover from that addiction only to die from the addiction of nicotine. So that, of course, is not a success. So which is why we want to practice integrated whole health care that takes into considerations a person's long-term recovery and well-being. Another thing I would like to mention is that we all know by now that smoking leads to at least 15 different types of cancer affecting the whole body. I remember when I first started this work, for some reason, I always associated smoking with lung cancer, but never breast cancer or ovarian cancer or stomach cancer. But now it's important for us to realize that the harmful toxins found in cigarettes actually damage our DNA on the micro level, leading to all sorts of cancers. So what does this mean for you all? This means that we as public health professionals need to stop siloing ourselves as the tobacco control experts or the chronic disease experts or the cancer experts or the mental health experts, and realize that tobacco prevention, treatment, and control is a concerted public health effort that really requires us to work across branches, agencies, and organizations. So where do we start with our collaborative effort? The great thing is that here in the US, we have such a robust set of tried and true recommendations, which include adopting tobacco-free grounds, integrating tobacco prevention, cessation, and treatment into mental health and substance use treatment and care, utilizing evidence-based practices for providers, so like the 5 A's, which is ask, advise, assess, assist, and arrange, and providing nicotine replacement therapy and pharmacological support, leveraging Quitline. So y'all have Quit Now Kentucky to collaborate with as well. Engaging peer models and people with lived experience, which has been shown to be really powerful to share those success stories and help motivate people to quit. And then last but not least, thinking beyond cessation to recovery. So to recap our main takeaways, individuals with mental health and substance use conditions use tobacco at a disproportionately higher rate than the general population. They are less likely to stop smoking without such conditions, but many with mental health and substance use challenges want to quit smoking and can't quit smoking at the same rate as the general population. We know it works. Using proven interventions can help reduce tobacco use among this population. And for more information on any of those evidence-based practices that I mentioned or touched upon today, please visit our website at www.bhistochange.org. We have resources on things like counseling, motivational interviewing, infographics, toolkits, you name it. Membership is free, and you'll be able to stay up to date with all things behavioral health, commercial tobacco, and cancer control related. I would also like to encourage all of you to go to our website and check out our resources and that of our partners, which includes comprehensive toolkits for statewide tobacco control programs, behavioral health facilities, and mental health and substance use treatment providers. And I want to thank Ellen because there are many local resources available to you all, which include Quit Now Kentucky, which is, as the name suggests, is Kentucky's Quitline program for people who smoke. In addition, there is behavioral health wellness environments for living and learning, also known as BHWell, which provides consultation regarding evidence-based behavioral health programs and is a wonderful place to start expanding partnerships and looking for experts at your state. So thank you all for giving me the opportunity to present to your state. I've left my contact information in case any of you want to follow up with our network regarding questions or any support. We're always willing to help you all that come our way, and if we can't help you, we'll certainly connect you to someone who can. And with that, I believe it's time for Q&A, so I'll pass the mic back over to Ellen.
Thank you so much. That was a wonderful presentation, and I really appreciate your mentioning BHWell there at the end. That was one of the organizations that I was going to talk about a little bit. Many of you all have worked with the University of Kentucky, specifically Zim Akoli and Emily Koyagi and Heather Robertson, who are part of that Be Well team at UK. A couple of you all do have grants specifically to work with your behavioral health facilities, and we are so excited about that. But this was such an important introduction for anybody who's not doing that yet, which I think I know that the majority of you all do not have funding specifically to work with behavioral health facilities, but there are still so many things that you can be doing, and that starts with knowing what resources are available. So with that, I will say, please continue to ask questions, put those in the Q&A box or the chat box. I will share as well in the chat box our evaluation opportunity. So this is something, if you've been on one of our webinars before, you're probably familiar with it, but it is just a quick little 5 or 6 question survey that lets us know what you all thought of the presentation and how we can make future presentations as excellent as possible. So I just sent that. And in the meantime, I am holding out for any questions.
Yeah, I know I covered a lot in that half hour that we had. And I'm sure you all are just digesting the content as well. But any questions you have about mental health or health equity or even community engagement, I'm happy to answer.
So Gary Hall has a great question in the chat. So Gary is with Green River District Health Department, but before being there, he was working with the community mental health centers. So his question is, when I worked at a community mental health center, the attitude of substance use disorder treatment staff of smoking was, well, they may need to keep one vice when trying to quit alcohol and or other drugs. Do you see this in other states?
Yeah, definitely. This is actually one of the top concerns that a lot of states and mental health facilities come back to us with when they're trying to implement change. And here at the National Council, we actually have a saying related to this, which is meet people where they're at, but don't leave them there. And it's important, I think, for a lot of mental health and substance use treatment facilities to realize that quitting tobacco actually increases long-term recovery for the substance that they're interested in. So again, that includes alcohol use disorder and opioid use disorder as well. And you want to, again, make sure to just keep on trying, be persistent. Even if the person is, heavily using cigarettes, maybe, they start off reducing that nicotine amount. So if they are smoking, 5 cigarettes a day, maybe cutting it down to 3. And also just reminding those mental health and substance use treatment facilities that, again, that 25% recovery, that's a huge amount that you can save. And really, is it worth it to save our clients from one substance only to see them suffer from tobacco use, long term?
Yes, that's so true. And we have been working with the University of Kentucky and Be Well with several behavioral health facilities and community mental health centers. And one of the misconceptions that we deal with is, and that they are dealing with, is this idea that you need to address addiction or substance use in the order in which it is going to kill someone, or the immediacy of the issue. Like, well, someone might overdose tonight on heroin or another product, and they're probably not going to overdose on nicotine, or they're probably not going to smoke too many cigarettes tonight to the point that it might end their life tonight. However, the importance of addressing all of these together and really going into that mindset of really we need to address all of these in the order in which people are willing to and encouraged to take action. And I loved what you said about meet people where they are, but don't leave them there. So thank you for that.
Thanks, Ellen. And we do have a resource on our website. It's called Making the Business Case, and it's specifically for healthcare executives that are part of mental health and substance use facilities, because even if the concern isn't, well, if I ask my clients to quit tobacco, they're not going to come back because they're using tobacco as their substitute. It's sometimes like monetary, where they think that if they go tobacco free, you know, all their competition are just going to rise up against them and they're going to lose business, which is also a myth. So that Making the Business Case fact sheet that we have is available on our website and goes into, you know, all those ROIs for you all and other ways that you know, adopting tobacco-free policies can help.
I'm just adding into the chat box the link for Be Well, which again is Dr. Akoli and his colleagues that some of you all may have worked with before. And then I am also going to share in an email after this to everyone who attended some wonderful handouts and resources that Samara shared with me. So you all have a full, you know, plethora of people that you can reach out to and ways that you can get more resources. We have time for additional questions, if there are any. Oh, and speaking of Be Well, Emily Koyagi just asked whether a recording or slides will be made available. And the answer is yes, this has been recorded and we do plan to share that. And Samara, we can talk offline about whether the slides will be shared, but definitely the recording will be available.
Sure, yeah, we definitely, we actually have a PDF copy of all of our slides on our website in addition to all of our partners. So I'll make sure to send a PDF copy to Ellen so she can share with you all as well.
Perfect, thank you.
And yeah, I see a question in the chat box, so I'll including the link to Making the Business Case. Yes, definitely, Ashley, I'll go ahead and send that to Ellen if I haven't already, to send you up in a follow-up email. And some other resources that might be helpful for you all. Like we have one specifically on tobacco-free grounds and how to implement change for tobacco-free grounds in particular. So I'll make sure to send that package your way.
Wonderful. Any other questions or requests? Okay, well, I'm going to drop this evaluation link in the chat one more time. There it is. And then I'm also going to say, as I mentioned before, we do have presentations coming up next month on veterans and the military, and then the following month on working with providers and the quit line specifically. So if you haven't heard about those or typically don't receive links to register for our webinars, please make sure that you have joined our listserv. And we have switched to a new platform over the summer. We're now using MailChimp. So you may need to go in and make sure it's not going to your spam filter or spam folder, or that it's not getting lost anywhere. Or maybe you need to register or sign up. So I'm also dropping the link to sign up for our newsletter right there. If you attended today, you will receive a link to this recording, and then the link to the recording will also be shared in future newsletters. So.
All right, so if you all do think of questions, maybe after the fact when you've had some time to look over the content again, please feel free to reach out to the wonderful team, you know, at Kentucky Tobacco Prevention and Cessation Program, or you can reach out to us directly. You know, we don't bite. You can send us an email any day, and we'll make sure to support you in any way we can. Thank you, everybody.